السلام عليكم ورحمة الله وبركاته.
Welcome to CompEdge Top 10 Practical Pearls, Imaging and Physiology. Every conference teaches lessons, but only a few moments leave a mark. At the close of this journey, we distill an entire day of science into 10 sharp, practical insights. Not theory, not speculation, but the pure essence of evidence drawn from imaging, physiology, and the collective wisdom of the fields. To guide us through the 10 practical pearls in intracoronary imaging and physiology, I am honored to introduce two voices of clarity. Please welcome Dr. Wisdom and Dr. Liyla, who will take us on this final journey, distilling today's science into sharp, actionable insights for tomorrow's practice.
Thank you, Dr. Raed. We stand ready to translate knowledge into pearls you can carry back to your cath lab.
10 truths. Immediate, fundamental, and unforgettable. Let's begin.
1. Angiography is a map, not a mirror.
Angiography provides only a 2D luminogram, a flat map of the contrast-filled lumen, not a true reflection of the coronary disease within the vessel wall. The subtle plaque and vessel remodeling that define coronary artery disease often hide beyond the angiographic silhouette. Intravascular imaging with intravascular ultrasound, or OCT, reveals this off-the-map pathology, ensuring we treat the disease that an angiogram alone might miss. In short, use imaging to see reality. The angiogram only sketches an outline.
2. When the angiogram looks normal but the patient isn't, go deeper. Microvascular tools aren't a luxury, they're the truth.
If a patient has angina or ischemia with normal epicardial arteries, chances are the problem lies in the microvasculature. In fact, over 50% of patients with angina and no obstructive coronaries have measurable coronary microvascular dysfunction, and about 25% have heightened vasoreactivity, spasm, contributing to symptoms. Invasive microvascular tests, for example measuring CFR, IMR, or performing acetylcholine provocation, are not mere luxuries. They reveal the true cause of ischemia. The landmark CompEdge trial showed that systematically testing for microvascular dysfunction or spasm and tailoring therapy accordingly leads to significant improvement in angina and quality of life. Bottom line, when epicardial arteries look innocent but the patient isn't, trust the microvascular assessment to reveal the truth.
3. Discordance isn't failure, it's a second opinion. Don't simplify, synthesize.
When physiologic indices disagree, such as FFR and IFR, or when imaging and physiology diverge, it doesn't mean the tools failed. It means we gained a second perspective. Not uncommonly, 15 to 20% of lesions yield discordant FFR and IFR results. Such discordance can be informative. For example, an FFR-positive, IFR-negative lesion might indicate diffuse disease with preserved resting flow, whereas an FFR-negative, IFR-positive result could hint at microvascular issues or flow augmentation. Crucially, studies show that simply deferring a lesion when one index is positive and another negative is associated with worse outcomes compared to truly concordant negative lesions. In practice, discordant data demand integration. Consider anatomy, plaque characteristics, and the patient's physiology as a whole. In sum, 2 tests telling you different stories? Listen to both and find the synthesis. It leads to better decisions than picking one and ignoring the other.
4. Pullback is the most underused superpower. It doesn't just locate the lesion, it maps the plan.
A continuous pullback assessment, whether with a pressure wire or an imaging catheter, is like an angiographic treasure map for intervention. It not only pinpoints pressure drops or plaque buildups, but also distinguishes diffuse disease from focal lesions, and reveals tandem lesions or physiological misses. The importance of this mapping was starkly shown in the DEFINE PCI study. 24% of patients had residual ischemia, abnormal IFR less than or equal to 0.89, even after angiographically successful stenting, with the vast majority of these cases caused by lesions or diffuse disease that the angiogram hadn't adequately identified. A pullback physiology scan in those cases would have lit up the untreated culprit segment and altered the game plan. In practice, doing a pressure gradient pullback or imaging run from distal to proximal converts raw data into a strategy. It guides where to extend a stent, whether diffuse disease needs medical therapy, or if multiple lesions need addressing. Think of pullback as your personal superhero, one that sees the whole forest, not just the trees, enabling you to chart exactly where and how to intervene.
5. The best imaging is the image you intervene on. Don't only document, decide.
Intravascular imaging should be used in the moment to guide decisions, not just before and after for documentation. Using intravascular ultrasound or OCT during PCI to size the vessel, optimize stent expansion, detect edge issues, etc., translates to real clinical benefit. Evidence is overwhelming. A network meta-analysis of 20 trials, 12,428 patients, found that imaging-guided PCI dramatically outperforms angiography guidance, reducing target lesion failure by approximately 30% and significantly lowering cardiac death and stent thrombosis. Notably, whether you choose OCT or intravascular ultrasound, both were superior to angio-only guidance in achieving these outcomes. In practical terms, this means the highest quality image is the one that actively steers your procedure. Size that stent based on the intravascular ultrasound measurement. Post-dilate until OCT shows no malapposition. Fix that edge dissection you wouldn't have seen on angio. Don't just record images. Use them to inform your next move in real time. Bottom line, imaging is not a passive observer. Make it an active part of your intervention strategy, and your patient will benefit.
6. Digital doesn't mean distant. AI refine your judgment. They don't replace it.
The rise of artificial intelligence and computational physiology enhances in cardiology doesn't distance us from decision-making. In fact, it can bring us closer to a fully informed judgment. AI and machine learning tools are designed to support and augment the clinician's expertise, not to supplant it. For example, non-invasive fractional flow reserve from CT can non-invasively map ischemia, and AI image analysis can flag plaque features or suggest an optimal stent length. These digital aids refine our judgment by providing additional data points and predictive insights. But the human touch remains paramount. We interpret the AI output in the clinical context, accounting for patient factors that algorithms don't feel. Current expert consensus and policy emphasize that AI should function as a co-pilot, enhancing accuracy and efficiency, while the physician retains the captain's seat. In short, embrace digital tools to sharpen your decisions, but never forget that your clinical acumen and compassion are irreplaceable in the care equation.
7. Microvascular disease is not a diagnosis of exclusion. It's a system in crisis, not a mystery.
Coronary microvascular dysfunction, CMD, has moved from a diagnosis of exclusion to a well-defined clinical entity, a systemic crisis in the smallest vessels that we can identify and treat. Rather than shrugging off persistent angina as mysterious when no large artery blockage is seen, we now have criteria and tests for microvascular angina, for example, CFR less than 2.0 and/or IMR greater than 25 as objective cutoffs. Research over the past few years has underscored that CMD is a serious condition with real outcomes. It's associated with high risk of major adverse cardiac events and significant morbidity. In other words, microvascular disease isn't benign. It's often a diffuse endothelial and smooth muscle dysfunction, a warning sign of systemic vascular ill health. The good news: it's not a hopeless enigma. We have emerging operatives. So don't stop at no blockage equals no problem. If the clinical picture fits, pursue the microvasculature. Key point: treat microvascular angina as the real deal. Diagnose it positively and manage it proactively, just as you would a visible epicardial lesion.
8. Your lab culture is a tool too. No device works in a system that avoids precision.
High-tech devices in the cath lab don't guarantee high-tech care. Culture and mindset matter just as much. If a laboratory's practice culture avoids precision, for example, routinely eyeballing lesion severity instead of measuring, or skipping imaging/physiology due to habit or false time-saving, even the best devices won't save patients. Despite abundant evidence that intracoronary imaging and physiology improve outcomes, these tools remain grossly underutilized in many settings. In a recent analysis of over 500,000 PCIs in the US, only approximately 8% used IVUS and less than 1% used OCT, with the vast majority, approximately 92%, done by angiography alone. Why? Often due to operator preference, lack of training or support, perceived extra time cost, and institutional inertia. In short, cultural barriers. Yet centres and operators that foster a culture of precision, where everyone values measurements and imaging/FFR is second nature, consistently achieve better outcomes. Make no mistake, culture is a cath lab tool. It can either enable or impede the benefits of any new technology. Building a culture that strives for precision, education, and team-based implementation of advanced tools is as important as the tools themselves. Take home. Invest in training, protocols, and mindset. A precise lab culture will let all your fancy devices shine for patient benefit.
9. Co-registration is not optional. It's how we should think. Fuse structure and function to guide treatment.
The future and present of optimal PCI planning is fusion of imaging and physiology, co-registering our structural and functional insights into one coherent guidance system. Co-registration technology, for example, overlaying intravascular ultrasound or OCT findings onto the angiogram, or mapping pressure wire pullback data onto the coronary tree, is more than a nifty visual. It's a mindset for decision-making. It forces us to think of stenosis not just in terms of an ambiguous percent diameter or an isolated FFR, but as a precise segment in a real artery with known plaque morphology and known hemodynamic significance. This approach markedly reduces ambiguity. In fact, studies note that co-registration can enhance procedural planning and reduce geographic miss, ensuring we stent the right segment and cover all the diseased parts, thereby optimizing PCI outcome. Function-structure fusion has already shown its worth. For example, IFR pullback co-registration has revealed diffuse disease that wasn't obvious, and intravascular ultrasound angio co-registration has prevented operators from missing a distal plaque when positioning a stent. We should make this integrated thinking the norm. Bottom line, always ask where and why before you treat. Co-register physiology with anatomy in your mind and on the screen, so that your therapy targets the exact right spot.
10. Don't just use AI, Audit it. Know what it's optimizing for, and make sure that's what your patient needs.
As we incorporate AI-driven guidance and analytics in the cath lab, we must remain vigilant and hold the algorithms accountable for their accuracy and reliability. Every AI tool is designed with an objective function. It's optimizing for something, whether that's detecting stenosis, predicting FFR, or standardizing image interpretation. But is that metric the same as what your patient needs? Symptom relief, fewer MIs, longer life? We shouldn't assume it is. We should verify. Experts in AI ethics urge regular algorithm audits in healthcare, checking for biases, aligning the AI's goals with clinical goals, and ensuring transparency in how recommendations are made. For example, if an AI recommends stenting a 40% lesion because it predicts vulnerability, we need to know what data that's based on and whether following that advice truly improves outcomes. If an AI-driven QFR, quantitative flow, algorithm flags the vessels for PCI, double check. Is it overestimating severity in certain anatomies? Does it account for patient frailty or only the artery? By auditing AI outputs against clinical reality, we safeguard that these tools remain our servants, not our masters. The aim is to let AI enhance precision without blindly steering us off course. In practice, trust but verify, leverage AI's power, but continuously ensure it's pointing toward patient-centric targets and be ready to course correct if it's not.
On behalf of my colleague, I extend heartfelt gratitude for the opportunity to share these pearls with you, and for your engagement in this journey through imaging and physiology.
My deepest thanks to Dr. Wisdom and Dr. Liyla for guiding us with clarity and scientific expertise, and to you, our audience. Thank you for transforming knowledge into practice and shaping the future of patient care. Until we meet again.
As of here, we reach the end of our session. Thank you, and see you in CompEdge 2026.